Our next presentation is shedding some light on the process of what a recipient goes through when they're getting worked up for transplant and while they're waiting for transplant. We're often asked, where is a patient at? What's happening? Are they active? Are they on hold? Are they worked up? Have they been seen? And this is all going to be revealed in the next half an hour. So speaking today are two of my colleagues. Andrea O'Shaughnessy is a recipient transplant coordinator at VGH. She has been with us since 2008 and has a lot of experience in many fields, including ICU and bone marrow transplant. She is involved in all aspects of the recipient side of transplant. Sharon Duncan, also a colleague of mine, is on the donor side. She's now just changed her role. She's a patient care coordinator and educator with the pre-transplant program at VGH. She's involved in both provincial and national committees, especially for living donor guidelines, and has been very involved in in the kidney paired donation program. So over to Sharon and Andrea.
Thank you for having us. So I'd like to start by saying Sharon and I do a lot of patient education around transplant process, the surgery, anti-rejection drugs afterwards, and so on. And today we're going to switch gears a little bit and talk more about what happens when a referral is submitted to us, and so that you, the clinicians, understand what the technicalities are, and that once a referral is made, it doesn't go into the abyss, I promise. There's something happens with it. So here we are, green light to transplant, our stepwise approach. What we hope you take away from this today is that you leave with an increased understanding of a patient's progression through the transplant assessment, and you have an enhanced knowledge of common delays to transplant, because that's often a bit confusing for people. So we all know the advantages of transplant, but just to name a few, patients report feeling better and having more energy after a transplant, freedom from dialysis, so of course increased quality of life and have more opportunity to do what they want. Travel has been a big one that a lot of people say, and added survival years for some. So how do you refer your patient to transplant? I'm going to start right at step one here. So the primary nephrologist identifies patients that they feel are suitable for referral, and usually it's when a patient's GFR is less than 25, and also that they expect that the patient would have at least a 5-year survivability. And so this is a big piece when people talk about, well, is my patient too old? What is the age bracket of people who are allowed? And we don't really look at age as much as their overall health and what their survivability is going to likely be, and of course you can't always know that, but it's an estimate, or somewhat. And of course all blood types are welcome. The primary nephrologist and their team submit the referral. So a lot of the nurses out there who work on the referrals, you know, you do a lot of the groundwork, and so thank you for that. So they put the referral in through the PROMIS database. Now it's no longer a paper trail that's faxed or mailed. And part of the referral is they also do some baseline workup for the patients. And so those would include things like chest x-rays, ECGs, viral serologies, and the such. And there's a list of mandatory tests in the PROMIS referral module that they would use to help them move through that process. And then once it's submitted, the referrals are reviewed by the transplant nurses. Here's a screenshot of the PROMIS referral form. And just so you understand where that is, it's in the PROMIS section under transplant. So some of the terms that we use in this system. So a home team will initiate and submit the referral including the baseline testing, as I mentioned. And then once it's submitted, the transplant program on our end will change the status to referral received on the screen. So if someone says, well, what's happening with this transplant? Has anybody looked at it yet? In Promise, it will show that it's been received, we've got it, we've seen it. And at this point, we will review and identify if we will accept the referral or not, and we'll talk about that some more. So referrals are accepted when the baseline testing as specified is complete, and that, sorry, I'm losing my spot here. And at that time, we also contact patients to discuss whether they have live donors, if that's been discussed by their home team, and that's kind of center dependent. If they have any further questions about the process thus far. Usually when a patient is referred to us, their home teams will give out new pamphlets or brochures we have and answer some of the questions they have initially, and we'll continue that on. Some of the reasons that referrals are delayed is if there's, for instance, a cardiac history and there's been no recent cardiac reviews or investigations, we'll delay the referral until some of that is completed. And the reason being is if a patient comes to see us and we evaluate them and we don't have any updates on their cardiac issues and we know there's a history there, we can't really give the patient a good idea of what the chances are for transplant. We can't say, well, you're a higher risk, or everything's going to go along smoothly. So it's good for us to have that information ahead of time. And so at this point, we would contact the home team and follow up with them about, can you please get these investigations, or we'll help you get these investigations. These are some of the common referral contraindications. So current complex infection, active malignancy, severe respiratory conditions, so anything that requires O2 support is a no-no. Active drug use or alcohol addiction, severe untreated psych illness, and there is a list on Promise as well. With that said, there are occasions where a home team will say, you know what, we think we'd really like you to see this patient even though they may have one of these contraindications. And at that point, we would encourage you just to give us a call and we can talk about it further and discuss if we would go around that or if there's further review necessary. This is another snapshot in Promise. This shows a list of the contraindications, and I think we got the gist of that this far. So how do we prioritize our patients for our clinics? Once a referral is accepted, we triage patients for clinic based on what we anticipate their time to transplant to be. However, because we know that sometimes when people come into clinic and we have opportunity to provide more information around live donors or what the waiting lists look like, they may be more eager to look for donors at that point and so on. So we do endeavor to see all referrals in a timely manner. So who do we expedite to clinic and put in my urgent box? We look at pre-dialysis patients, so those who are preemptive, and we want to try and transplant them ahead of requiring dialysis. If they have identified or potential living donors for direct or paired exchange. And the people who are possibly HSP candidates. So we talked about highly sensitized registry yesterday, but just to touch note on that again, if we get a referral and the patient's had multiple pregnancies, if they've had prior blood transfusions, if they've already had a transplant, they may be eligible for that highly sensitized registry, and so we'd want to see them quickly and see if we need to get them on that list. Delayed bookings. So this usually happens more from the patient end. When we're trying to book a patient in, they'll say, you know what, I'm really busy right now, I have work, I can't get away, or I can't get a babysitter, or I live on the other side of the mountain and I can't get through that pass during the winter time, I'd rather come in the spring. And so we talk about the implications of a delayed appointment and so on, but it's really a conversation that we have with the patient about when it's appropriate time to bring them in. So occasionally we have to postpone bookings or cancel bookings we've made because the patient's been recently admitted back into hospital. There's new complex infections or medical issues that maybe need to be resolved before we see them, because again, it comes down to if we don't have all that information handy when we see them, it's harder to give them an answer as to which direction we're going. If they have a new diagnosis of cancer, that needs to be taken care of first. And also, as we all know, a lot of these patients have a lot of comorbidities. So if there's a new diagnosis and a new problem, and then we're like, oh, and come into transplant while you're at it, it just adds extra work for them, and it's extra stress for them. So we hold off sometimes. And of course, these things all come back to having conversations with patients and their care teams. So we also have patients sometimes that do recurrent no-shows. They've said they're coming, they don't show up. And then so what we'll sometimes do is postpone booking them again, go back to the team, go back to the patient and say, what are the barriers for coming, and what's your rationale here, and try and support them through that. So I'm going to pass the mic over to Sharon, who will now talk about the next steps.
So the patient's been referred successfully. The referral has been accepted. The patient has a green light to transplant clinic. Patients often ask us why they have to come to Vancouver to one of the transplant centers for, excuse me, assessment. Parking, as we all know, is exorbitant in this city. Driving into Vancouver, even from the Lower Mainland or from areas like Chilliwack, is stressful. So what happens in pre-transplant clinic? Why is it that the primary nephrologist or referring nephrologist can't assess them? Patients are introduced to the multidisciplinary team when they come into transplant clinic. The multidisciplinary team includes social workers, transplant nephrologist, surgeon, nurse, and sometimes a psychologist or anesthesia. We provide education and information. We build on the information that's been given to the patients in the transplant or referral center, or the referral center, CKD, hemodialysis. We want to discuss things in detail, like waiting times for transplants, what the differences are between some of the different blood types, what the options are. They get in detail education about immunosuppression. We want to provide support and tools for patients looking for a live donor, and some of you went to the social worker Carolyn's presentation this morning about donor outreach. So we're able to do that. We identified their individual transplant options like deceased donation, kidney paired exchange, HSP, and in some small select cases, ABO and compatible transplant. For patients coming from outside of the Lower Mainland, and for some patients in the Lower Mainland also, we have them see the social worker, sometimes the psychologist. We obtain a medical history and document a physical exam, and for any of you that see some of the letters that come back from the transplant centers, they can be multi-pagers. Our purpose in having them seen in the transplant clinic is really to assess the patient's individual risk and benefit of transplant. I often say to people that they come away from transplant clinic with a much better idea of whether or not they're, where they're going in the assessment and whether or not they're going to be approved. So who gets approved for transplant, and how does that happen? We have weekly multidisciplinary rounds with the transplant program, and we review the patients that were seen in the clinic that week. At the rounds, patient assessments and test results are discussed, sometime in great detail. Many of the patients being reviewed are very complex, and we often find ourselves discussing the same names come up over and over again in our rounds, because we need additional information before they can be fully activated. We also discuss status changes. So patients that maybe are active or need to go on hold, new information is reviewed, and that new information is usually coming from the referring centers. We also discussed surgical dates and priorities for live donation. Our theory or our goal is to schedule live donor preemptive transplants first and get our preemptive transplant population done. This is a screenshot of the activation page for in Promise. So when the patient is approved, the patient status will appear as one of the following in the activation screen. Activated, activated hold, pre-dialysis approved, and in some cases approved for live donor transplant. And generally that means that they have a donor who's been worked up and approved. And sometimes that does happen, that we approve the donor before we have approved or activated the recipient. So the decision to activate, patients also come in to see us with the notion that by virtue of being referred that they're already on the active transplant list, and we hear that a lot. Well, I thought I was on the transplant wait list because my team has referred me. So sometimes they're surprised that they're not on the active list. Once the patient is seen in transplant clinic, the patients are activated when their testing is complete, or sometimes just minor things are outstanding, things that aren't generally supposed to make a big impact on their suitability for transplant, that the risks and benefits are acceptable to the team and to the patient. And you know, as I said, that's discussed during transplant clinic, and that the patient has given informed consent and wishes to proceed. So, you know, do they feel that transplant is the right option for them? There are sometimes decision delays, and that may be because significant testing is required for the patient. So that could be a situation, like Andrea was saying, a patient with a coronary or cardiac issues who needs a coronary angiogram. Sometimes medical complications require specialist consultations, and that can take you know, several months to get in to see the specialist. Some infections require treatment, such as TB, cellulitis, or there may be procedures that have been booked by some of the referring centers or even by family doctors that are pending. So an example of that would be a colonoscopy, breast biopsy, and sometimes weight loss is necessary in order to reduce the risk of complications to the patient during the surgery, during transplant. And generally we say that patients should have a BMI of less than 40. Also, in some cases, if a patient is not adherent to medical therapy, we may delay the decision. Patients are declined for transplant generally when comorbidities just make transplant and the risk of transplant too high, or the immunosuppressive therapy, the risk of that is too high for the patient. In some cases, a patient may decline the offer of transplant, or they're unwilling to complete the required testing. And it does happen that in some cases, a patient requires, for example, an angiogram and refuses to have that done. Whether a patient is approved or declined, letters are sent to the patients and to the referring centers. If there are delays, both the patient and the home team will be informed of what the delay is, what's being done to address those delays by the transplant program, and often the home team's help is needed to identify a patient's barriers to completing required testing. So it could be about needing further education about why the test is actually necessary, or it could be things like lack of finances or support to get to appointments. So once approved for transplant, there's a number of different options. So hopefully there's different options for the patient. We want to optimize any chance for a transplant, and so all transplant options are explored. These include for patients who don't have a live donor, deceased donor transplant, the BC wait list, the highly sensitized program, And for living donor transplant, direct donation, so i.e. compatible donors, kidney paired donation, or blood type incompatible transplant. A recipient without an approved live donor will be placed on the provincial transplant waitlist according to blood type and dialysis start date. If live donors step forward after a patient has been put on the wait list, then we will assess them, and the patient will remain on the wait list until the donor is approved. A patient may be called in for deceased donor transplant once they're on the active list quite rapidly if the patient is unsensitized, so their CPRA is 0 or on the lower spectrum of sensitization, or blood type A or AB. The wait times are shorter for those two lists. A live donor transplant may also go forward quite quickly if the patient has an approved direct donor or has an approved matched and paired exchange. So once matched in the kidney paired donor program, the programs across the country, as we know this is a national program, programs are anxious to move forward with transplant within about 2 to 3 months once the patients have been matched and the chains of transplants have been approved. That process can be a little bit arduous. Blood type incompatible transplant can also go ahead quite quickly. The average wait time for a blood type B or O transplant is a little bit longer, generally longer. Patients who are sensitized are known to have a lot of antibodies, as I mentioned, are difficult to match, and some of us saw the presentations about that yesterday. It may also be more difficult to match sensitized patients in paired exchange, and most likely some of you have got patients who have been in paired exchange for some time and are still waiting and hoping to find a match. In some cases also the donors aren't approved, and most donor assessments take approximately a year. We tell donors that they can proceed through the testing at their own pace. Part of the reason for that is that we don't want them to feel pressured or coerced. We want them to make an informed decision, and a decision that's right for them. And just like the recipients, the donor assessments can also be complex. They may need more than standard testing. They might need scopes themselves. They may need cardiac testing. Ambulatory blood pressure monitoring is very common. And the time to transplant can be delayed. Out-of-country donors, as we know, we live in a province where out-of-country donors are, they're common. Lots of patients have donors that are living in India, China, the Philippines, and so they can also pose another challenge in that there may be delays in getting an entry visa to Canada, or that somebody is actually making applications and they're being denied. So that process in itself can take some time. In some cases, we need to put a patient who's on the active transplant wait list on hold. And that may be because they develop a new complication or an infection, something like peritonitis, in which case they may require, I think it's about 6 weeks before they can be relisted. Or they may have an admission to the hospital, or they travel outside of BC, and so we know that we can't reach them, or they can't make it back to the transplant center in a timely way. Sometimes they've had a recent surgery and they need some recovery because of that. So patients ask often if they lose their place if they go on hold. They're listed according to dialysis start date. Do they lose their place and have to go back to the bottom? And no, of course not. So they maintain their place on the list. Some patients need to go on hold for an extended period of time while different issues get sorted out. When we call in a patient for transplant, we want to be able to get in touch with them quickly. We need them often to be at the transplant centers quickly. We live in a big province where, it's the difficulties of traveling to Vancouver exist, or, flights are difficult to book, or winter driving, all kinds of challenges like that. And so we want to know that the patients who are on our active list are active and ready to go, they're transplant ready. And so the communication between the referring centers and the home teams and the transplant centers is really important in terms of letting us know when some of these issues, like new issues, new complications come about, because we may need to put them on hold, and we don't want to. We want to have a list that's ready and accurate and up to date, so that we can get patients in and transplanted safely. So in conclusion, getting the green light to transplant involves many steps. It involves all of us, transplant centers and referring centers alike. Again, we just underline the importance of communication, and of course our overarching goal is to have patients have a seamless transition to transplant.
Thanks, Andrea and Sharon. I see a lot of questions here online. Does anybody have any questions they want to ask through the microphones? Sorry, the lights are shining in my face. I can't really see people. So I'm going to go through some of the questions here that people have written in. First question, does persistent non-compliance with prescribed dialysis treatments have an impact on a patient's eligibility for transplant? So, Andrea, do you want to take that one?
Can we start with an easy question, please? So actually it was interesting because I just sat in on Dr. Strajek's talk about adherence, and it can, but we really look at the whole picture with the patient. So let's say it's a young patient, they're having a hard time complying with their dialysis runs, they're trying to work, they can't afford to not be working and things like that, and it's a tough schedule maintaining their dialysis, they have a hard time remembering their meds, they want to be like their buddies and just go out on Friday nights, and this is cramping their style. And we know that after transplant, they're going to have to comply with their meds, and they're going to be stuck with us for a little while in the post-transplant clinics, but overall they're going to have probably an easier time with a transplant than they are with their dialysis, and so we consider those things. If we think it's a lack of education, we work on that. If we think it's just not a value they hold to take care of these things, then of course that has to be reviewed. There are times where we will hold off on moving to transplant, partly because we think, well, if they're really struggling with compliance now when we transplant them, then they could lose that kidney early, and then they're potentially sensitized, and the second time around it's going to be harder to get them a transplant. So it is something we don't take lightly.
So I see another question here, and I think Sharon answered it, but just to reinforce it again, do patients on hold get credit for the time lost or not? And I think Sharon answered that question. They go back to the position they were in on the wait list, and they stay in the same position even if they're on hold, and they keep moving up, so they don't lose their place. They don't get credit, but they don't lose the place that they were in. They may have lost a transplant in the meantime, though, while they're on hold. So we try and minimize the amount of time somebody's on hold on the wait list. So another question. So when patients on the wait list ask how long is the wait time for transplant, where should we direct them, or what answer should we give them? Sharon, do you want to answer that?
Sure.
So when patients on the wait list ask.
Yeah, we often get phone calls about that too. Where am I at on the wait list? It's not a really straightforward question because we have patients who are highly sensitized who may actually be, physically at the top of the wait list. And sometimes we're having to jump down 30, 40 patients on the wait list to find somebody who is compatible. So it's not, in the old days before we had PRAs, we used to be able to actually look at the ranking of a patient and say you're, number 50. We really can't do that anymore. So if patients call, we do try to educate them about all the different factors that come into answering that question. So it's in general, though, we do know if for somebody who's not sensitized, we may have an approximate time for when they would be moving forward with transplant. So.
Can I also add, just have them call us, because like Sharon was mentioning, there's so many factors involved in each individual situation that it's probably easier just to have the patient call us and we can go over those things. And even if they don't fully understand what the implications are of if they're highly sensitized, for instance, we can reiterate those things.
So we've time for one more question. And I see a question here, it's an interesting question. Is there a patient portal to view their place on the wait list? This is actually something that we've talked about over the last couple of days, getting feedback from around the province on what are the needs for both patients and particularly patients who are on the wait list, and they're getting very anxious to know what's happening. And hopefully over the next little while, we hope to develop some kind of portal that they may be able to access online or through an app, that they can see where their position, not their position, but where they are in their assessment, active hold, etc. Because that will be good communication for the patient as well. But it hasn't been developed yet. It's something that we've just kind of thought about in the last few days. So hopefully by the time we talk next year, we'll have something to tell you about.